And welcome to the AAP Virtual Town Hall on preparing your practice for the 2020-2021 influenza season. I'm Dr. Sally Goza, President of the Academy, and I'm glad we're all here tonight. This coming influenza season will be like one that we haven't seen in quite some time, and it will be one of the most important ever to not only preventing the spread of the flu, but also reducing the burden of an already incredibly taxed healthcare system due to the COVID-19 pandemic. My practice has been struggling with how are we going to do this, so I'm looking forward to some great ideas here. We've come up with some, but we're still looking for ways to make it even better of how we're going to do this in our office. We're so excited that we're all here taking the time to discuss this very important topic and hear from AAP members around the country on how they're preparing their practices for delivering influenza vaccines in the context of COVID-19. And I'm going to turn it over to Mr. Del Monte right now.
Thank you, Dr. Goza. Appreciate your welcome and for laying that out for us. This flu season is of significance on a number of levels, as you've just said, Dr. Goza. And so it is important for all of us to gather. We're looking forward to having a couple of hundred members, several hundred members of the American Academy of Pediatrics joining us tonight. And so it's important for you as the president to kick us off and to focus us on the content for this evening. We're pretty excited about this event and excited about the lineup of speakers that we have for you. We are going to spend a little bit of time introducing the speakers, but mostly we're going to get right to their topics. And so let me begin with a little bit of housekeeping items right up at the front here. While this webinar is going on, your lines will be muted. And so if you need to check in with us, please use the question and answer box down at the bottom of the chat column there. If you are having technical problems with WebEx or struggling with any of the technical pieces, please do feel free to enter those questions into the chat box, and we will do all that we can to help you. You don't have to wait to the end to submit your questions. Submit your questions as they come, and then when the panelists are all finished speaking, we'll return to the Q&A and make sure that we get as many questions answered as we possibly can. And then lastly, on the opening slide is that we are recording this webinar. And so this webinar will be available to everyone afterwards, and the content will be available as well. And so please, let's just get rolling here. Let's go on to the next one. There we go. This is, as I just mentioned, everyone is muted as we started in. If you have any problems at all, please put those into the chat box. And if you have questions for the panelists in the discussion, you can use the Q&A box at the bottom of the screen there. We'll get to as many as we can at the end. As I mentioned, this is being recorded. Before we get to the flu, though, let me give you a little news and focus on one related item. If we could have the next slide, please, and that's the Provider Relief Fund. We have been working for a very long time to make sure that all of the members of AAP have access to the relief that is provided by the CARES Act in the Provider Relief Fund. And so I have two important pieces of information to share with you. First, that the deadline for applying for financial relief through the Provider Relief Fund portal has been extended until August 28th. So for those of you who have not applied or you have pending applications, you have now until August 28th to meet that deadline. Secondly, we have shared many concerns that we have heard from our members across the spectrum about the complexity of the portal, the difficulty of the application, and we are pleased to report that HHS has announced that it will be providing a more simplified application form coming soon. We don't know what that application form looks like, and we don't know how much more simple it will be. We're hoping for more. And congratulations to all of the members who have made it through the previous form with all the complexities that that last portal had. We know that our members have received relief funding through that fund. So if you have not, now's the time to think that through. We continue to work with HHS about easing the ability of our members to get access to that. And we were able to successfully ensure that pediatricians, pediatric medical subspecialists, and pediatric surgeons who received the payment from that initial round in the Medicare-based funding, that round one, can apply now for a second payment in the Provider Relief Fund. So we had lots of stories about people who got negligible amounts of money in the very beginning and were unable to true it up, which was the HHS term, in the second round. That portal will now be open to let folks go back in and get all the way up to the maximum that they were entitled to, even if they just got a little bit of money in the first round. So that is a big victory. We want everybody to access that who can. That is open on August 10th. And so we will be working with you to make sure that you get all the information you need between the 10th and the 28th to get access to those resources. We know that HHS is taking meaningful steps to helping our members apply for the funds, but we still have a lot of open issues and challenges about tax identification number challenges, et cetera, for people who are struggling with this. And so we will continue to press the case. But as an overall matter, it is very important for no pediatrician who is eligible for this relief to let that relief stay on the table. This is one of the only times that the federal government will provide you free money, and we want to make sure that the federal government does that. And so if you need help, send an email to covid-19@aap.org. We still have important questions to answer for additional relief for those folks who do not take Medicaid or have had other challenges in the program. So stay tuned for more information about that. All right, let's begin then. We begin with Dr. Flor Munoz-Rivas, who is an associate professor of pediatrics and molecular virology and microbiology at Baylor College of Medicine. She is a member of the Committee on Infectious Diseases of the AAP, the Influenza and Pertussis Working Groups of the CDC Advisory Committee on Immunization Practices, and special interest groups of the WHO, NIH, and other organizations. Dr. Munoz has over 20 years of experience in conducting clinical research focused on the epidemiology of infectious diseases and vaccines, especially in populations of infants, children, adolescents, pregnant women, and immunocompromised hosts. So let's begin directly with Dr. Munoz. Thank you.
Thank you very much, and good evening, everyone. I've been asked to just give you an update briefly about the AAP influenza vaccine recommendations, which are going to be available to you for this year shortly. And so if we can move to the next slide, please. The vaccine recommendations for this year have not significantly changed. The AAP continues to recommend annual influenza vaccination for all children that are 6 months of age and older. That is our standard recommendation. For this year, as in the previous year, any licensed influenza vaccine that is appropriate for age and health status of the children can be used for vaccination. And the AAP does not have any preference for a particular vaccine product or one over another for children with no contraindications for influenza vaccination, or for whom there is more than one licensed age-appropriate vaccine available. Next one, please. So we do need to understand clearly that there will be many challenges this season. As has been mentioned, this is a season different from many others because of the COVID-19 pandemic. And these would be some of the examples of the potential impact of the pandemic, the fact that patients need to be able to access care, access vaccines, and the fact that we need to have implemented enhanced infection control measures and pandemic control measures in our different settings and institutions. So for this, there's guidance that is available through CDC where the AAP is following that guidance. The next slide is giving you some of that information. And basically, we agree that vaccination in the medical home is the ideal recommendation. This allows not just for routine care of our patients, but also routine immunizations. And what will be important this season is to make sure that all children are up to date and that catch-up immunization is implemented, because we understand that there will be potentially delays and missed vaccinations at this time. In terms of infection prevention measures, if this comes up, we do support, of course, the screening for symptoms, physical distancing, and other respiratory and hand hygiene that needs to be in place. Specific guidance regarding the administration of influenza vaccine. When it's an injected vaccine, it's only sufficient to have a face mask and eye protection for these administrations. And with LAIV, face mask, eye protection, but also gloves, just in the case that there could be any contact with respiratory secretions of the child. Thank you so much.
Dr. Munoz, thank you for that important overview to get us started. And now we will hear by three members of the Academy of Pediatrics who will share with us how their practices are preparing for the upcoming influenza season. First up will be Dr. Brian Etheridge. Dr. Etheridge attained his medical degree from the University of New Mexico School of Medicine in 2004 and completed his residency in pediatrics at the University of Louisville School of Medicine in 2007. He has worked in Silver City, New Mexico for 13 years in both private practice and at Hidalgo Medical Services and FQHC covering rural Southwest New Mexico. Dr. Etheridge is active in local and regional medical committees and an associate clinical professor of pediatrics at the University of New Mexico School of Medicine. He is active in student and resident education and the immediate past president of the New Mexico Pediatric Society and current Robert Wood Johnson Foundation Culture of Health leader. Dr. Etheridge.
Good evening, everyone. Thank you for the opportunity to contribute. So as Mark said, we have all of us have a kind of a list of three questions. So the first question is describing our practice practice setting and where it's located in the patient population that I serve. So I work for HMS, which is the Federally Qualified Healthcare Center in Southwest New Mexico. We cover about 20,000 square miles as far as kind of patient service area. We're in the southwest corner of New Mexico along the U.S.-Mexico border. We have 16 clinical sites ranging from care from obviously pediatrics to OB, mental health, dental, senior services, and family support. We have approximately 84,000 patient encounters per year. 80% of our pediatric patients are covered by Medicaid. Our nearest primary referral centers are primarily at the University of New Mexico in Albuquerque or at Presbyterian Hospital. But I should also state that when we get into kind of a crunch situation, that I deeply appreciate my colleagues in El Paso, Tucson, and Phoenix. So the next question is, what do we envision the challenge facing pediatric practice as we moved into the 2020 or the influenza season? These are interesting times for all of us. You know, there's significant financial stress, you know, decreased visits or kind of, you know, rapidly increasing costs, you know, with PPE. We have numerous staffing challenges with regards to our nurses, medical assistants, other support staff, or even for pediatricians with schools being online or partners being furloughed or other financial, you know, stresses. We're all suffering from, you know, significant fatigue. This has been a challenge, you know, for everyone, you know, or the entire planet. And so there's lots of, you know, where, you know, people are tired, and so we've all been suffering from kind of the personal protective equipment issues that the country has faced, you know, and reuse and all kinds of other things. For a lot of our families, the sky has fallen, that they're unemployed, they have all kinds of issues, whether it be from technology, Wi-Fi, mental health concerns, domestic violence, food insecurity. From a, you know, organizational perspective, how do we manage, you know, patient flow via video or in-person visits, and kind of this surge of, you know, that we expect to see later this year. On the positive side, I think we have some opportunities, and it's letting us really rethink things and how we do, you know, things as an organization, or, you know, even as an academy, or, you know, kind of as a pediatricians and pediatric subspecialists. HMS is preparing for the upcoming influenza season in a variety of different ways, and as far as to how it's going to be different, it's just a bit more challenging, I think, is the quick one there that I would summarize. So for key areas that we've been looking at is being flexible and adaptive. I mean, this has been a challenge for all of us to really, you know, rethinking how we can be more flexible. Video visits However we can, adapt or change or modify our systems, or, to get patients in to immunize them. Another area that we've really been focusing on is education with parents. And so some of this is, what to expect, later this year to kind of really prepare them, and to encourage them to wear masks, what that looks like if their child is sick, how to access that kind of care, and to be supportive, supportive to them. We have been educating patients really early this year with regards to flu vaccine at the earliest that we've ever done, stressing the importance to the healthcare system, that this is really important in a state that has only 1/3 of the hospital capacity and critical care capacity of our surrounding states, that this is something that parents can do to really help the community and help kids, and help all of us kind of get through this, and being, really engaging them and empowering them to get involved with, getting flu vaccine or, vaccines. We as an organization have also created a task force, of kind of the frontline practitioners, nursing, administration to meet weekly, to look at all these different issues from, how are we going to do this, to how do we support practitioners and medical assistants with schools, and trying to be really creative and kind of have ongoing discussions as to what this looks like, for our organization. We continue to partner with schools and the New Mexico Department of Health in a variety of areas, and try to encourage immunizations or support kind of, drive-through clinics. We're looking at weekend clinics, using mobile units for kind of our targeted populations or high-risk populations. And then, and as far as with flu vaccine, engaging at every opportunity we have. So if we have patients in the room or their parents, we're going to try to really engage, and get vaccine done as efficiently as possible. And I think that, and then with and again, I think the key thing is being honest and kind of preparing patients, and being really supportive of them, and then also supporting our staff, that we will get through this, and, we will get it done. And so, so thank you.
Dr. Etheridge, thank you. I appreciate that very much. We'll look forward to your participation in the Q&A as well. We'll move on now to Dr. Nadia Koreshi. Dr. Koreshi graduated from Aga Khan University in Pakistan, completed her pediatric residency at the University of Illinois Chicago, and a pediatric infectious disease fellowship at the University of Chicago. Dr. Koreshi has worked at Loyola University Medical Center since 2014, both as a general pediatrician and pediatric infectious diseases physician. She is passionate about vaccines and has done several continuing medical education talks and local projects on HPV vaccine and vaccine hesitancy. Dr. Koreshi is currently medical director for Loyola's outpatient pediatrics and assistant clerkship director for pediatrics at Stritch School of Medicine. Dr. Koreshi.
Thank you so much, Mark, for this introduction. So as Dr. Etheridge was earlier contributing to, that we all have been given this task to basically address some of the information from an experience and share our own experiences in terms of our practice settings, location, patient population, and come up with some of those ideas. Next slide, please. So I was asked to discuss about my practice setting. So Loyola University Medical Center, it's an academic institution. We have a medium-sized pediatric residency program with about 30 pediatric residents, 16 med-peds residents, and 6 general pediatric faculty at our clinic, alongside with some of the other pediatric subspecialists that have clinic right there. We also have a big patient population with hematology oncology patients, and we share the same waiting area and same clinic space with them. Along with, in our outpatient setting, we have other specialty clinics happening side by side. We do have lab, radiology, all present on site. Our location, for those of you who are not familiar with Chicago, so Chicago is famous for being a big city, and Maywood is a small suburb but it's actually only 15 to 20 minutes from the downtown. It's about 10 miles. And it is located on the same main campus where we have the main hospital, ER, Peds ER. We also have the medical school, nursing school, as well as close to a VA hospital. In addition, so this is our main, clinic location, but there are various satellite clinics all over different suburbs of Chicago, along with many immediate care centers that are located as well. In terms of our patient population, so we see a really mixed patient population when it comes to racial ethnicity. I was trying to look at the new data, but approximately we have about 1/3 Hispanics, 1/3 African Americans, 1/3 whites, and I would say like 7 to 8% of different other ethnicities such as Polish speaking, Arabic speaking, Vietnamese, and basically mixed patient population. In terms of our payers, about 60% of our patient population is Medicaid, and 40% are private payers. So a lot of them, rely on the VFC vaccine, so vaccine for children, and about 10%, I would say, or less would be for CHIP vaccines. Next slide, please. So before I discuss the challenges that I envision in the upcoming flu season, I wanted to show just a comparison of the cumulative rate between COVID-19 and the flu according to the age group. And I know this is already outdated because by the time I have sent my slides, now we have the new data available that has shown in the last 2 weeks from June to July, we have had more cases in pediatrics. But even comparing to that one, if you look at between 0 to 4 years, it's 8 as per the slide, and the recent one is showing about 12 cases per 100,000 population. For 5 to 17, it's showing 3.7, and it has doubled to 7. But if you look in comparison, the flu cumulative rate, it is way, way higher. And this just highlights that for pediatric population, the flu has been a greater threat that COVID has been so far. And again, these data may be skewed because of the school closing and the social distancing, but given the same circumstances, we are seeing way of far more risk of hospitalization in children and adolescents. It's about less than 1/5 of what the risk of hospitalization from flu is during even the previous season of 2019 to 2020 for the same age group. So, so we know that this is the time to talk about it. That how are we going to prepare ourselves, because we know that flu is always been way worse for pediatrics than COVID has been so far. Next. So I see challenges twofold. One of the things is to ensure that our patient population is going to get flu vaccines. So the flu vaccination uptake. The other thing is evaluation and testing for these influenza-like illness, which could be influenza, which could be RSV, which could be COVID. So one thing is regarding the vaccination, and the other one is regarding evaluation and testing. So just some background and some context before I talk about it. One of the things is the flu season onset. So we know it's always difficult to predict when the flu season onset is going to be. And the timings of the outbreaks historically always vary in different parts of the country. But usually we see it, peaking in December to January, but sometimes it can start as early as October. And then depending on the type of the flu virus strain, sometimes we see flu A starting early and the flu B follows later. Just when we think, the season is ending, then the new strain comes up. Recently, I just wanted to bring up that recently there was a study done by some of the investigators from China and UK, and they have brought this concern that there is a swine influenza strain type of an H1N1 that has a special reassortment of genes and some of the several genes from the 2009 pandemic flu H1N1 as well, and it may have the potential to become a human pandemic strain. I don't want to freak everyone out because so far since last 1918 swine flu pandemic, we've had 3 more pandemics in over 100 years in terms of flu. But this is, again, a concern that would that be circulating this year, next year, we don't know yet. In terms of vaccine effectiveness, because I know this comes up a lot because the patients are not happy. I got the flu vaccine. I still got the flu, and no one knows about the vaccine effectiveness until the season is gone. So the biggest thing is to, remind our patients and even our colleagues that every year the new flu vaccine comes out, thinking about, predicting what would be the strains that would be rotating at that time of the year. And if the vaccine is a good match, then we see a good effectiveness or a different one. So last year, the flu season that passed, so earlier in the Feb, it was showing that it was about 45% effective, and it had way better efficacy for flu B strain, about 50%, and less for flu A. And it also had variation with the age group. So in some age groups, it was actually doing better. By the time it had, the season had concluded, and as we know, towards the end of the season, the vaccine is not as efficacious, especially in older patient population, because it loses its effectiveness because of the waning immunity, as well as because of, virus keeps mutating as well. So the overall, what they found that the vaccine efficacy for the last year flu vaccine was 39%, with a confidence interval of 32 to 45. And one of the things I always tell, parents, that even if the vaccine is not 100% effective in preventing the infection, it is effective in preventing the complications and death associated with it. And this is the only chance we have, right? And especially getting into, this COVID pandemic, there's no way we're going to have a vaccine for SARS-CoV-2 during the same time we're going to have the flu season this year. So this is the only chance we have to at least prevent one of the common illnesses. The other question that keeps coming up and concern that people keep bringing up is, what about the co-infection of flu with SARS-CoV-2? Are those patients going to be sicker? We don't know yet. We'll find out when all these viruses will be circulating what's going to happen. The other thing, especially for pediatrics, RSV season, that also coincides the same time. That can, especially for younger age groups, less than 2 years of age, we see RSV being one of the big problems and one of the major causes for hospitalization. And historically, we have always, during the flu season time, we do the molecular testing with one swab for PCR for flu A, B, and RSV. Typically, throughout the year, we have available multiplex respiratory PCR, which checks for about 18 different viruses and bacteria. And this year, they have already added SARS-CoV-2 in that big multiplex PCR. But again, that one is expensive, and that one you shouldn't be using for every patient. Specifically in the flu season time or getting into the winter, we have to be cost effective and make sure that we're doing it at the right time. So what we are planning to do at our hospital, with one swab, we're going to be checking the flu RSV PCR. We'll also be checking the SARS-CoV-2. So they're two separate tests. It's not a quad test. They're two separate tests, but with one swab, we'll be able to do it. Some of the other things that we all have adapted to very quickly is video visits. And I feel like we all need to still keep on doing video visits, and especially trying to separate our sick from well child check that we've been doing. In terms of some other preparations, so if your patients have portal, please start messaging them through a patient portal, send them automatic reminders. You can still continue to do traditional in-office nurse visit, anyone, but you have to see according to your clinic whether you can do it by appointments. I would recommend doing it by appointment so you can plan it out. You can do the social distancing. We're also planning to have specific times for flu clinic in the after hours or weekends so that there are not going to be other patients in the waiting room. We also have this mobile vaccination unit that we have used for, sorry, my time is up. We have used for school physicals, but we are planning to do it as a flu vaccine too, and then trying to vaccinate adults at the same time. And that is it.
Thank you so much. I think there was a question in the chat about your mobile clinic, and so maybe we can get back to that with give you a chance to give some more detail about that in the Q&A discussion. Thank you so much. That was great. Next up is Dr. Jeannie Marconi. Dr. Marconi has been a practicing pediatrician for over 25 years and is now an educator and consulting physician. She has been very active in the AAP as past president of the Connecticut chapter and within the section on administration and practice management, or SOPM, as well as the advisory editorial board to the Committee on Coding and Nomenclature. Among her numerous innovative services for primary care are in-house urgent care, infant and maternal breastfeeding services, early health and wellness promoting nutrition, as well as services for evaluation and treatment of asthma, obesity, and related diseases. Most recently, her early telehealth adaptation to WellCare and her long history of drive-through flu clinics has reached national publications, including in the New York Times. So we look forward to hearing all about that. Dr. Marconi, welcome.
Thank you so much, and good evening, everyone. First, I wanted to thank the AAP for bringing attention to this potential unprecedented flu and COVID season, and more importantly, really for keeping us so informed and advocating for all of us over the last 6 months. I can't begin to tell you how many members have just given so many kudos. So if everybody could virtually clap, it would be really great. We really appreciate everything that you have done for us, especially this year. Tonight, I wanted to challenge you to perhaps think out of the box a little bit in how you want to administer the flu vaccine, and quite frankly, any other vaccine, or potentially even some of the services you already do in your practice. Our practice setting, we are about 50 minutes from New York City. We are a suburb. We have 2 offices. We have about 33% Medicaid, and all of our vaccines are VFC now in Connecticut. We also have been using our second office. We have turned it into the sick office. So all of our sick patients are seen in that office, which has really allowed us to keep almost on target with our well visits, med checks, and chronic disease management, which has been really amazing through these past several months. We also have been doing drive-through clinics for about 18 years, and it first came to my attention when in a parking lot of some supermarket, a coffee kiosk toll booth appeared. And I thought, oh, that would be great to do step tests, like drive in one way and drive out the other. And then some light bulb went off, and I thought about what if we could do flu vaccines this way? And so it began. So we have been doing these for quite some time. So I'm hoping to share with you tonight a little bit about how that might work in your practice. And, I have been thinking the last few days, well, what if you don't have a parking lot? But I think you could probably do a hotspot in your office, like in your waiting room. So many of these same sort of thoughts and directions could apply to a hotspot clinic. So why drive-through? I think it's efficient, it's expedient, and it's really enhanced by the COVID pandemic. We can do many, many patients an hour. People don't even have to get out of their car. The patients love it. It is very well received. And it does involve a lot of management and detail, so I hope we're going to speak about some of those tonight. And then I hope after this, we will be able to post some of the other slides that I have that you might be able to use in your practice. Next slide, please. So why do we want to adapt different methods of flu vaccination this year? Well, the most important one is we want to limit exposure for people, not only patients to us, but for us to patients, because we have to see other patients. So we want to be able to get them in quickly and easily. We also, I think, want to think about once the COVID-19 vaccine comes out, we want to have a rapid way of delivery. So this could be your dry run. So you can practice and see how it goes. In terms of setup, you need to, of course, have a parking lot. But if you don't have one in your building, I have worked with practices that have used their bank, used the business colleague. So there's always some parking lot somewhere available on a weekend where you can sort of have a drive-through operation going, and your general liability policy usually covers you for these things, just like you would if you did a health fair somewhere. We had to get permission from our landlord to do these flu clinics. It's very easy. I also have a handout on a license that you can share with your landlord if you decide to do it on site in your parking lot. Of course, you need some contingency plans for rain and weather. My nurses have done it in the rain. They wear a slicker. We have a pop-up tent that we put out in the parking lot, and there's a drive-up check-in station, a drive-in administration station, and away they go. Next slide, please. So these are the main things that you would want to think about in setting up your drive-through clinic. Scheduling. Online scheduling is really the way to go for this because you are doing mass appointments. You don't want thousands of patients now calling your office. We just got 2,000 vaccines in. I can't imagine 2,000 patients wanting to call us and schedule their flu visit. If your EHR doesn't have online scheduling, we use Full Slate, which I have been using for 18 years. You can actually schedule 35 patients in the same slot. It is really quite amazing for your practice. Even if you did this walk-up hotspot clinic, you could use the same system, limit all of the work that your staff needs to do at the front desk. Also, I want to mention scheduling is an opportunity. It's a huge opportunity for many practices because you should check your patient's charts to see, is their physical up to date? Is their med check up to date? Is their chronic disease up to date? And your staff will have time to do this because typically they're scheduling out the flu clinics next week or the week after. So you can go through the list and get everybody caught up as we're going along, especially since many of us missed many opportunities over the last 6 months. In terms of scheduling, we do about 12 cars an hour. Some of my nurses can do 15, and there's usually 3 or 4 people in the car. It goes very quickly. It's really, really very easy. We also do parents, like Nadia was talking about before. They register ahead of time online. We do not bill insurance for parents. We actually, it's a little cash business for us. We don't make tremendous money, but we do make some. And I encourage you all, it's also a family thing to drive up. Everybody gets their shot, including mommy and daddy, and off they go out to breakfast. It's sort of like an event now for many families over these past several years. In terms of materials, the CDC has a great website. It's cdc.gov, and it's vaccines, healthcare workers, and then mass sites. And I will have Dana post that for you. It has a wonderful guide on how to set up flu clinics off-site, and I encourage you all to take a look at that. In addition, one of the most important things is cold chain considerations. If you're doing vaccines outside, you want to make sure that you maintain a thermal environment for the vaccine. So a thermometer, a proper cooler, ice, and all of those things are critical in terms of giving vaccines through a drive-through. The vaccines that become problematic are the frozen ones, which is varicella, and those, when we were doing telewell visits earlier this year, before even the insurance allowed us to, we would do the pre-visit on the phone, and then they would drive up and the nurse would run up and get the frozen vaccine and bring it down. Not ideal, but it got the job done. So those things I would really look on the CDC, very specific items for you to take back. There were 2 stations in our parking lot. There's an intake station where an MA sort of takes a brief history. Who are you? Are you on the list? Were you pre-verified? So we do all of our insurance pre-verification and all of that ahead of time. So there is no waiting. Our VIS are also done through our patient portal, but in case they didn't do it, the intake person would do the VIS, and then the car would pull up to where the nurse is who would administer the vaccine. We also ask if the driver is the one who's also getting the vaccine, we ask them to pull into a designated spot for a couple of minutes, especially HPV vaccines, if we're doing those. We have the teenagers, usually, or young adults, pull into a spot for 10 minutes or so just to make sure that they're okay. And then, as in any good Boy Scout, being prepared for emergencies, you need to have your emergency kit right on hand. You need to have one of the staff have a cell phone that will be easy to call into the office for assistance, or 911, whichever, but you want to make sure that you have your red code card and all of the things that you would need for anaphylaxis or allergic reaction and those kinds of things. Next slide, please. So one of the more important things about doing this flu clinic, especially if you're going to be the first practice in your community to do it, is why not, grab the opportunity and promote your practice. So you can promote these drive-through clinics through social media, through your portal, through your emails, your practice newsletter. You can call your community news people and say, hey, we're doing this first, flu clinic to limit, patients' exposure in the medical office, to get them done quickly, to immunize so many people. You would be surprised how much mileage you can get out of adding any new service to your practice, but especially this one in COVID times. Also, teach your own staff what you're doing. Just don't run a flu clinic and then a lot of your staff don't know what's going on, especially with COVID and parents being teachers. to their children and being in and out, you want all the staff to know what's going on in your practice so they can also better educate your patients. Change your phone message on hold and announce your flu clinics. As I said, do a press release, put signs in your office, and be sure you follow the details, but also choose someone to organize this that can be a champion in your practice, somebody who's detailed oriented, and that will probably gain you the most success. Thank you so much.
Dr. Marconi, thank you very much. Very helpful and interesting. Let's move right along then to the advocacy side of this. We've already had some questions in the box about advocacy and a number of questions on VFC, et cetera. And so let's turn it now to James Bomberger. James is the Senior Director of Federal Advocacy in AAP's Washington, D.C. office, and he will close out the presentations for us with an update on AAP state and federal advocacy related to vaccines and immunizations. James.
All right, thank you very much, Mark, and good evening, everyone. Earlier this summer, we put out this ambitious federal advocacy agenda for strengthening childhood immunization. We put it out in the context of at the time, plummeting childhood vaccine rates due to stay-at-home orders and COVID-19, in a time when practices were really struggling financially due to serious declines in case volume, and of course, all the while dealing with continued vaccine hesitancy that we've struggled with for years. So what we have tried to do here to policymakers is make the case that now is really the time for Congress to invest in vaccine delivery infrastructure. It is needed to keep a strong vaccine infrastructure to make sure we're catching up on the vaccines that kids have missed, to ensure that we're having a strong flu season in the fall, and of course to prepare for when we have a COVID vaccine finally available to administer to children. Next slide, please. So our goals here, increasing vaccine rates and vaccine confidence, and doing this by encouraging the federal government to help us encourage parents to bring their children back to their medical homes for vaccines, that their medical homes are safe, and it is crucial not only for kids to be getting vaccines, but also be receiving primary care well-child checkups. In addition, we've asked the federal government to really take a really proactive role in addressing vaccine confidence and decreasing vaccine hesitancy. Through our support for legislation like the Vaccines Act, we're calling on Congress to fund federal government programs to do massive public awareness campaigns about the importance and safety and efficacy of vaccines. And finally, addressing the financial barriers, the financial difficulties that the practices face administering to vaccines to kids, addressing insufficient payment, and also strengthening the important Vaccines for Children program. Next slide, please. So on the financial side, one of our the centerpiece of our agenda here is really increased Medicaid payment for immunization administration, really addressing the fact that many state Medicaid programs pay very insufficiently for vaccine administration. And so what we're asking for is enhanced Medicaid payment for vaccine administration, fully funded by the federal government, as we know that states' budgets are in turmoil right now, and federal money is really needed to be able to innovate in this area. We've also asked for the federal government to fix inappropriately low valuation for 90460 in the Medicare physician fee schedule. I'll talk more about that in a minute, as well as working with state Medicaid programs on a state level to provide prospective or enhanced payments for vaccines. Next slide, please. On the VFC side, we've asked for incentive payments for providers who participate in the VFC program, increasing regional maximum fees for VFC administration, ensuring that children in the CHIP program can be eligible under the VFC program, as well as ensuring that practices can get paid for administering VFC vaccine to uninsured children. We've asked for some changes in how VFC runs its programs, particularly giving providers additional flexibility, allowing borrowing between public and private vaccine stock. This is an area where state VFC programs have already in the last few months decided to be much more flexible, and we're really happy to see that. Prioritizing delivery of seasonal flu vaccine to VFC providers is something we've urged CDC. We're working closely with them on that issue. Fixing VFC payment for administering multi-component vaccines, et cetera. Next slide, please. So, as you know, Congress is still unfortunately negotiating its next COVID package. We are engaged talking with members of Congress about these important issues and other issues for kids. As Congress continues, we'll continue to be lobbying hard on kids' issues, but we have had some wins in the meantime. And one of them is a really good news out of CMS on the physician fee schedule. As I mentioned, we have the 90460 code has been very inappropriately valued. Recently CMS put out its proposed 2021 Medicare physician fee schedule, which more than doubles RVUs for 90460. We are very excited about this and are very hopeful that these payment rates will have an important downstream effect in private pay, Medicaid, et cetera. We are also working with Congress to urge Congress to implement this early. This would not become finalized until January 1st. We'd like Congress to implement this immediately, and to also fully fund the federal government to ensure that similar vaccine payments could also be provided by state Medicaid programs. And then lastly, I will just say we've also been, of course, working at a state level and have had a number of wins in the past year. Maine, of course, beat back an attempt by ballot initiative to overturn a strong vaccine requirement law. Virginia has aligned its school vaccine requirements with AAP and ACIP's recommendations. Colorado also passed a bill strengthening non-medical exemption requirements. So AAP chapters have really played a big role in all of these victories and are continuing to try to address these vaccine policies on a state level. And with that, I'll turn it over to you, Mark.
James, thank you so much for all of that. And I would like to just linger on this slide a moment longer with a note of gratitude. The undervaluation of the immunization codes has been an issue that many pediatricians, some of whose names I recognize in the chat box already, have been working on this for a very long time. And so to get the revision of this did not happen by accident, and it was the result of lots of hard work by our members and in close coordination with staff. So we now have to push this across the finish line. As James said, we got to get it turned on early if we can in 2020, and also work to make sure that at the state level there are no impediments to payment. And so that there are a couple more steps down the stream. But until and unless we could get the codes revalued, we were really stuck with this. So I'm really grateful to everyone who has been working on this. It seems esoteric until you realize how real it is. So thank you to everybody working on that. Let's go on to the next one. Before we get to the Q&A, there's lots of great Q&A, and I think we'll have a good amount of time to do it. I do want to make sure that you're aware of some resources that AAP has developed. We have a suite of interim guidance in response to COVID-19, including practice management tips, et cetera, at aap.org. A number of questions already in the chat box and questions that were submitted are related to the interplay between the challenges of COVID-19 and the upcoming flu. And so some of those resources will be informative to you there. For questions that we don't get to tonight, there is a very robust discussion board that is at aap.org in the resources section. Feel free to post your questions there, or as additional questions come up after tonight. There is a nice back and forth, and people are helping each other out and answering questions there, sort of peer-based support and mentoring here. And then there is a tremendous amount of immunization content at aap.org, immunization pages, which are shown here as well. So we're trying to give you all of the resources that you need. So, all right, great. Let's go right to the Q&A now. Go back up to the top. There were a couple of initial questions about the timing of vaccinations, and this might be perhaps targeted towards Dr. Munoz. If your vaccine has arrived now, but the window is not when should the window be open? When should people begin to vaccinate, assuming that they have vaccine available now? Is there guidance from AAP and the CDC on the timing of beginning?
Yes, the guidance is the same as it has been for the last 2 seasons. So for every patient, the recommendation is that they should receive their complete influenza vaccination by end of October. Now, this is important, particularly in pediatrics, because we do have children that may need 2 doses of vaccine. And that means that they will not be completely vaccinated until they receive those 2 doses. And there are 4 weeks between the 2 as an interval between the vaccinations. So it is really important, especially for those children receiving 2 doses or needing 2 doses, that vaccination is given in a timely manner so that they are fully vaccinated and fully protected. And for children who only need 1 dose, also vaccination by October is appropriate. The recommendations have now changed in the sense that if you do have vaccine available and you have the opportunity to vaccinate, it is best to not miss the opportunity to vaccinate at this time.
Thank you very much, Dr. Munoz. I think, Dr. Koreshi, were you nodding or did you want to comment further? I'm happy to.
No, I totally agree with Dr. Munoz that we don't want to miss out on any opportunity, and especially it takes for pediatric patients, the one who need 2 dosages, after of the 2nd dose is when they're immune. That's why trying to vaccinate them as early as possible whenever they're eligible.
Thank you so much. There are a couple of questions, variations on questions on sort of PPE and vaccination, both in the office setting and then out in the parking lot with you, Dr. Marconi. So maybe we could take those in order. What about eye cover and those kinds of questions?
I think it's the same. I think for in office and in the car, it should be a mask and goggles. And if you're using the LAIV, then you should, also make sure that you really have good protection over, use the face guard and gloves, actually.
Terrific. And Dr. Marconi, can you keep going? There was a lot of interest in your model. One, and I think, Dr. Koreshi, you have a mobile clinic as well, but what do we do about this squirming toddler in the car? What do you do about mom or dad, and do you have them wait to drive after their immunization? And so those kinds of questions.
Yeah, so actually giving the vaccines in the car is easier. They are in their car seat. There is very little room for them to squirm. So my nurses feel it's much better. And most kids are in car seats till 6 or 7 now. So it's pretty easy. And our patients have learned, like, come in a diaper or come in shorts or come in, something very loose fitting and just put the heat on in the car. So that answers that question. What was the other question? I'm sorry.
About the adults. And do you have them wait or?
Literally like 5 minutes. We ask them to pull over. The flu vaccine really, I hardly ever worry about the flu. It's more the HPV that the teenagers will have them pull over and really wait 10 minutes or so before the nurse will let them go. But the nurse does, say, okay, let me just wait here a minute, while she's getting ready for the next car. She's sort of like looking in. We also designate 2 or 3 spots where they can actually pull into safely, because one of the most important things is safety in the parking lot. We don't want people getting out of cars and backing up and all of that kind of thing. So we have a designated spot for them to pull into.
And one more on that one. What about liability issues and who's the patient? And does your medical liability insurance cover the non-pediatric patient in that setting?
Our liability company, and we've had Coverus and MD Advantage, both of those, I would suggest you call, actually cover any caretaker or parent that is involved with the health of the child. We are covered for that. And our general liability policy covers any issues in the parking lot, which your general liability policy normally does. So if something happens to your patient in the parking lot, it's actually your insurance that gets tapped into.
Thank you. Terrific. Next sort of large category, there's lots of questions about testing and the interplay between testing flu influenza and then COVID-19, and then related questions about a fever, and several of you touched on different aspects of that, but maybe we could go around. Dr. Koreshi, it looks like you're nodding. Do you want to start with some of those questions, and maybe we can go on to Dr. Munoz and go down the line?
Sure, I was just seeing some of the questions, and I know that there's so many tests that are out now, and everyone is using different testing modalities. So even at Loyola, we have 3 different tests available right now, and we're going to have 4th one available soon. So one is an Abbott MT2000, which has a turnaround time of about 6 to 7 hours, and it has a great about 90% or so sensitivity. Then there's Abbott ID Now point-of-care testing, which gives you a result in as early as 5 minutes, but up to 15 minutes. And that, if it's positive, it helps because they're not false positive with it, because it's a molecular test. But if it's negative, there is about it's about 75 to 85% sensitive. So you may basically miss 15 to 25% of the cases. So we use it for like in our immediate care centers, it's in use. And if someone is symptomatic and if the test is positive, you stop there. But if the test is negative, then it gets reflexed to our MT2000. Then we have another 45-minute test, CPID. So we have like different indications for all these different tests. And the one that I was talking about, we're going to have this bigger machine, again, through Abbott soon, which will be able to have 900 tests done at the same time, run at the same time. And there's no test yet that has both just the RSV, flu, and COVID together. But with one nasal swab, we can run our usual RSV, flu PCR, as well as the COVID test PCR as well. So we don't need to take 2 separate tests, so the orders are as 2 separate tests, basically, because I see there was some confusion and questions about it. So I hope that answers.
Thank you so much. Dr. Munoz, would you like to comment further?
Yeah, so maybe what I would like to comment is regarding who to test and why. So, clearly, as we are talking about the respiratory season coming along, and not really knowing how this will play out. We know, for example, with experience in the Southern Hemisphere, that it's their winter time right now. They basically have been seeing mostly COVID and very little of the other viruses. We've had COVID here for a little bit longer, so it's not clear whether we will see other respiratory viruses. Anecdotally, I can tell you in my institution, we are starting to see rhinoviruses and TU adenoviruses, so it is possible to have COVID and another infection. And so COVID is clearly the virus to also look for in anybody who is presenting with clinical symptoms. So if you have a symptomatic patient, I would suggest that you do want to include testing for common respiratory viruses, including flu and RSV during the winter, of course, and also COVID. And indeed, the testing can be done in the same swab. PCR testing would be the preferred test for diagnosis, as opposed to antibody testing, for example. And also, you might want to consider, in terms of who to test, patients who might be at risk, and there's a very nice list of who would be at higher risk for complications if they have been exposed. And clearly, we know children can be exposed and then develop symptoms later on. So yes, definitely encouraged to always look for COVID as we look for other winter viruses.
Thank you. And just to follow up on the point of care, what's the recommendation about PPE in point of care testing? That one question came in about that.
So for any testing, you should be wearing eye protection and at least a surgical mask, because it's not considered an aerosolizing procedure. So taking a nasopharyngeal swab is still considered a non-aerosolizing procedure, so you should be able to still wear just a surgical mask and eye protection in addition.
Thank you. Thank you. Dr. Marconi, I think this picture that you may have showed in your slides showed you were in gown and glove, eye protection as well, going through the car window. Is that how you're doing it?
Yeah, so that picture was a vaccine being given at a physical. So before we were allowed to do the telewell all via telehealth, we were doing telewell via the phone, and then later that day they would come to the parking lot for their brief exam and a vaccine. So that was actually during an exam that they were also wearing the shield. But for the actual flu clinic, it's really just the mask and goggles.
Terrific. Thank you.
Can I answer one other question just briefly? Of course. It's hit me like 3 times. So some people are asking how they could do this if they don't have a parking lot, and I'm suggesting like a hotspot clinic either in your waiting room or your back end of your office or the lobby of your building if it's on a weekend, where everyone signs up the same way we talked about for the drive-through. They sign up online, and it's a 2-stop station as well. So one stop, the MA can ask the COVID questions, take a quick temp, sort of check them in, make sure they're on the list, and the next one they get their flu shot and back out the door they go, sort of like a revolving door, in and out. So I think there are ways to adapt the drive-through to some of the other environmental situations that people may have with their location.
Thank you. Dr. Koreshi, you had a comment on this topic as well.
So I know that he had asked me earlier about the mobile van, because some people were asking, I didn't get a chance to clarify. So we have a mobile van that traditionally we have sent it to the schools to get the school physical done, especially for our pediatric patient population who do not have insurance, and we give them vaccines at the same time with those school physicals. So right now we are trying to utilize, especially with the schools being closed or remote learning, and still some of the schools have expressed interest that we should come out. But some of the other things that we are looking into is maybe using it as a for sick visit outside our clinic. But there's some logistics that we are trying to work around, and the other idea was actually to use it as a flu vaccination one as well. So there are different ways, and depending on, again, your situation and setting, you can decide what you can do.
Thank you so much. There are more questions on the kind of nuts and bolts of the operation of the mobile setting or of the drive-through, but I do want to make sure we have just about 10 minutes remaining to switch to a few topics, additional topics. One is about vaccine hesitancy and the interplay between vaccine hesitancy in general and inducing populations who have low vaccine uptake historically back to the clinic. And so maybe Dr. Etheridge, could we start with you about in an FQHC situation, how do you counsel about flu and encourage families to take the flu vaccine?
So they kind of make fun of me on that one, because they say that it's almost a year-round affair, that we start handing, actually, as many of you I'm sure are aware, the Children's Hospital of Philadelphia has great all kinds of information sheets. So that at every opportunity when we start seeing patients, pretty much 10 months of the year, normally we're talking about flu vaccine, how it's important. Unfortunately, I think all of us have really, some, all kinds, unfortunately, all of us have seen, patients who've had, significant events with influenza or even death. And when I start talking, about, how every year I load a patient in an aircraft who's critically ill, and kind of those things that it's real life, those things really do happen, and kind of, engaging with them with their concerns, which I'm sure we all, do. And it's, and sometimes it's a multi-year process and then, engaging. And I will say that this year it's been really fascinating because we have a subset of patients that normally don't get flu vaccine that they make fun of me that I've tortured them for years, but this year they're going to, because I'm saying this is really important. I'm literally begging you on my knees to do this. And so, and then, providing them with information, talking about it. I will say, just as an aside, I'm sure we're all kind of seeing this too, that with a potential COVID vaccine at some point, the parental anxiety and hesitancy there is going to be dramatic. And so, but I think that the key thing is hitting it constantly and constantly giving information and talking about it and stressing it. And it starts with, my medical assistant to the nurse, and kind of doing it, on a routine basis, that this is important every year for your child. And I think it works really well.
Thank you very much. Any other panelists want to amplify those comments about increasing uptake?
Yeah, I would just agree with Dr. Etheridge. One of the things I feel like parents don't care about statistics. They don't care about research. If you give them millions of hospitalizations are being saved, they don't care about that. They care about that anecdotal experience. They care about the sample size of N. And just how Dr. Etheridge was saying, I see patients who are being airlifted. That's how sick they can get. So the personal experiences and personal stories is what they want to listen to. I actually even tell them, and because some of my patients have told me, we forgot to get flu vaccine for one of our kids, and though we all got started, but the one who did not get the vaccine was sick for like 7 to 10 days. The ones who had gotten the vaccine got better within a day, or barely had fever for 1 day. So those anecdotal experiences, I think, really resonate well. The other thing I want to say, I am also scared about this vaccine hesitancy when even the COVID vaccine comes out, because already some of our patients have started asking, you're not going to give us that COVID vaccine yet, right? And we're like, we don't have it. So a subset of patients are actually really eager now to get the flu vaccines, the ones who haven't, but there is a subset who have gotten even more further, away from getting it. So.
Thank you very much. Dr. Marconi, did I see you nodding on the messaging part of this?
No, I'm good.
I missed you.
No,
okay.
I agree totally. I agree. Our practice, unfortunately, had 2 kids within a month of each other die of the flu, and we had mass vaccination. The community went into panic, and since then, I think our immunization rate for flu has just stayed way up there. They do not want to go back to that time in our community. So the unfortunate event actually created some positivity in terms of now getting the flu shot. So,
thank you. Thanks very much. There were a number of policy questions and advocacy questions in response to James's presentation. A number of questions about borrowing. And advocacy for borrowing, and also timing of shipment of flu vaccine, particularly VFC vaccine versus private stock. And I think I'll just make a comment myself about this and see if James wants to follow up on those. We know that CDC was very concerned about influenza this year, and so we believe that the VFC order reflects an ample supply, an increased supply actually of influenza vaccine. And so we are pressing to make sure that the timing of that is resolved. That has been an advocacy issue for many years. With respect to borrowing, we know that borrowing is an issue across all vaccines, not just influenza, and that some states have allowed that. And so there is a very important role for AAP state chapters here, and for our members to be working with their state chapters and their state VFC programs to make sure that that all the available options that a state can take that are permissible under the VFC program are taken, and that's an advocacy opportunity. So sometimes the VFC program is like the Medicaid program. There's the federal policy and then the state uptake, and so there really is an opportunity to persist in states to allow borrowing, working with your state chapters. And so, James, do you want to make additional comments about that? But these are perennial challenges.
Yeah, sure, Mark. Thank you. And we have really close coordination with the folks at CDC who run the VFC program. We talk to them at least twice a month and exchange the thoughts that we're getting from our members and what they're seeing on the ground as well. So it's a really good relationship. The way the CDC runs the VFC program, they're not making national policies. Each state runs its own program. So that does make it a little more difficult. But the fact that you have seen some states be more flexible with borrowing indicates that the federal government is being more flexible when states are asking to work with them on these issues. If your states have not become more flexible and you'd like to see your VFC program take some action in this area, that's something that is ripe for advocacy on the state level. I don't know if I just want to give Ann or Dana the opportunity to chime in there if there's anything else you'd like to add.
Let's give them a chance to pop in, but we're almost at the end of the time here, and what I would like to do at the very end, Dr. Edwards, we saw you there. Were you speaking?
All good. Stay in touch. We're on it. Thank you.
Perfect. Let's go with just one last lightning round for all of our panelists here in the last couple of seconds that we have left, to make sure that you can make a final point that you didn't get made or that you think needs to be addressed. And we'll start with you, Dr. Munoz.
Thank you so much. So I would just say, again, thank you for all your work. It is challenging. We have to be flexible. We have to be nimble. We have to be keeping in mind our goals and our purpose. And that is to take care of these children that we have under our responsibility, that the parents have allowed us to take care of. And vaccination is part of it. We know that we continue to have, again, many challenges thrown at us, but we have been able to get through. And this is not going to be any different this winter. And I think that, just count on each other and be able to get through this winter season. Flu is one of the components, COVID is another, but other immunizations are also critical for keeping our children healthy. Thank you.
Thank you so much. Dr. Etheridge.
No, I would just reiterate that we do a drive-through flu clinic, and it works awesome primarily with adults, but looking at modifications of that. And then just, thank you for the opportunity to contribute, and then, everybody stay safe. Thank you.
Thank you so much. Dr. Koreshi.
Thank you so much for giving me this opportunity to be able to participate. One of the things I just want to give some hope to everyone. I feel like all the places, especially where there's mandatory masking and hand hygiene and watching their distance, I feel like we are hopefully not going to see a bad flu season, because this is the same way that the COVID we are preventing, but we're also going to be preventing flu. And I'm hoping that at least that even that some subset of patient population who is agreeing to get the flu vaccine, we are going to have a much better flu season. So
thank you so much.
I will get through this.
Oh, that's wonderful. Yes, every single person on this call is with you, and we hope that you are correct on that for sure. Dr. Marconi.
Yes, thank you again for the opportunity tonight. And I would like to offer to Dana to post a full slide set of how to prepare and implement a flu clinic, and hopefully she will let you know where that may sit so that you can have a line-by-line sort of checklist of how to go about setting this up in your practice. I know this was the abbreviated version, and I'm sorry that you didn't get all the details.
Dr. Marconi, thank you. We will take you up on that for sure. And so let's see, James, last thought?
Thanks, everyone, for the work you have all done over many years on improving vaccine policy, particularly vaccine payment, and we're working hard for all AAP members on this, and we'll continue to be in touch with you when advocacy opportunities arise.
All right, thank you, James. Well, thank you, Dr. Goza. Thank you, Dr. Munoz, Dr. Etheridge, Dr. Koreshi, Dr. Marconi, James Baumberger, and the more than almost 400 people who were with us on this call. This is an important topic. I hope that a lot of people will have learned much from what you said. I'm sure they did, and this will be available as a resource into the future. To all the questions that we didn't get to, sorry, and we will catalog all of these and try to make sure that there are answers available as this gets posted. They were all crucial questions. We just ran out of time. So with that, thank you everyone for joining us, to all the panelists and all the participants, and good luck and take care. Be safe out in the world, and we'll be back in touch. Bye-bye, everybody.
Thank you.